weekly GECCO webinar session hosted by the Gastro Foundation in association with Project ECHO. We've received 106 registrations today from 12 countries, and the chat session is open, please, for questions. Would like to welcome back Professor Martin Hale and Bilal Bobat, who host these chat sessions, which have been dedicated to the liver. And I might say that this will be the last of the hepatology pathology sessions. Our plan is at the next pathology session in about 5 weeks to begin a GI luminal pathology session, which we will then continue. The topic today is an important one, and that of autoimmune hepatitis. The prevalence is not known in sub-Saharan Africa, but a very important condition, and we'll highlight today.
I can't hear you. You've got a bad line. Okay. I'm not so sure what side it came from.
I'm on the desktop. Can you hear me?
Yeah, it's from your side. It's not very clear.
Is that better?
No, it's not.
Can you hear me at all?
I can hear you, but it's there's a lot of noise in the background when you speak.
All right, so let me just
That's
turn
better.
okay. Then let me just brief it up and just hand over then to Dinan Parbhoo, who's a gastroenterologist with an interest in hepatology at the Wits Donald Gordon Center in Johannesburg, who will present the 2 cases. Over to you, Dinan.
Thank you, Prof. Good evening, everybody. So this evening, we've got 2 cases on autoimmune hepatitis, and let's start. The first case is a Mr. CM, who's a 42-year-old male from the DRC, presented with no significant past medical or surgical history. He had no known allergies. He was a non-smoker, did not consume any alcohol, and denied any recreational or herbal drug usage. He had no family history of liver or intestinal illnesses and worked as a farm supervisor on a maize farm in the DRC, and he couldn't exclude any possible pesticide exposures. He had presented 3 months prior to arriving in South Africa to the DRC, a local hospital, with an acute onset of jaundice. This was intermittently treated during a couple of admissions to hospital with corticosteroids, and at the end of March, he presented to South Africa to one of our referral hospitals. At the referral hospital, workup was performed. His viral studies were negative. His celiac studies, Wilson's, alpha-1 antitrypsin levels were normal, noted to have an elevated ferritin and a transferrin saturation, and HFE genotyping was performed, which was negative. Of note, his autoimmune workup revealed an IgG of 21.9 with a normal IgA and IgM. He had a smooth muscle antibody positive at 1 in 40 and a borderline AMA-M2. The rest of the autoimmune liver workup was negative. On endoscopy, he had no features of clinically significant portal hypertension, and on ultrasonography of the abdomen, he was noted to have a coarse liver, which was normal in size, a normal portal vein with normal flow, spleen at 13 centimeters, but with no ascites. So these were bloods done at the referral hospital, and you will see that his bilirubins during this 2-week period and his ALT, AST over this period steadily rose, and he was started on PRED 40 milligrams and AZA 75 milligrams after the 6th of April. And he was referred to us on the 15th with these worsening liver function tests. He had uncontrolled HETs at home. He was feeling unwell with malaise, pyrexia, a bit of diarrhea, and he had noted mild pedal edema. We elected to admit him for further investigation at this point and reviewed a liver biopsy that was already performed with Prof. Hale. Prof, over to you.
So thanks, Dylan. I'll just share the screen. So this was an interesting case that was seen by two of my colleagues, Dr. Mizuko and Shwanti and Dr. Cheryl Ngwenya. And the expert opinion is certainly appreciated, and they certainly assess this biopsy, and it's absolutely correct as far as the diagnosis is concerned. It's a very interesting case. So just starting then to look at the low power view of this biopsy. I take it everybody can hear me, sorry. Cheryl, can you hear? Great. So you can see it's a very busy looking biopsy, and you can see that under low power there are these extensive, rather blue basophilic areas which represent foci of inflammatory infiltration. And you can see that it really is quite extensive. And this is a feature throughout the biopsy. We'll come to the dots shortly. So you can see that there really is profound liver injury in this biopsy. What I want to do now is show you the reticulum stain. And you can see in this particular stain that there is extensive reticulum collapse. We'll look at that in closer view shortly. But you can see that there is an impression of nodularity, for example, here and here and here. These areas here represent entrapped hepatocytes within the areas of collapse. And if we have a look closer examination, one can see that we've got this extensive reticulum collapse, and then you've got this trabecular framework, and there's no real twinning of hepatocyte plates. So although it looks nodular, it is not yet cirrhotic. It certainly would appear that there probably is architectural distortion which is occurring in this biopsy. You can see these radiating plates and still retained an element of organization to the trabecular framework. And these areas of entrapped hepatocytes. What I want to do now is show you another stain, and this is a connective tissue stain, and this is the serous red. Now the serous red, I'm just making a punt, if you like, for the serous red because it's a particularly good stain to demonstrate collagen. And you can see that the collagen is represented by this red staining, which is staining with the serous red. And you can see the entrapped hepatocytes here. And you can see under lower power, one can get an idea of the nodularity. And this is important because the reticulum, in fact, if you like, overstates the liver injury that is present as far as the fibrosis is concerned. Because you can see, although you've got this nodularity, it hasn't really yet progressed to cirrhosis. But you can see this delicate sort of pericellular fibrosis that you got in this particular biopsy. Now, the serous red is particularly useful for two reasons. First of all, you're really just seeing two colors. You're seeing the background counter stain, but also the red staining of the collagen. It's an easy stain for those of you who are the histopathologists on the call. It's a quick stain. It only takes an hour, and there's only a single reagent which is required. And it's the same reagent that we use to stain amyloid. So every lab would have it. And then this is the mass on trichrome. And the mass on trichrome shows similar changes. But you can see it's a much more, if you like, sort of busy stain. There's quite a lot of overstaining in this particular example, and it makes interpretation sometimes quite difficult. And the Masson can be quite a tricky stain to actually do. It requires differentiation, and the histopathologist will know what I mean by differentiation. It requires the technologist to continually look at the stain to see how things are progressing. If done properly, it's a good stain, but often, in fact, it is tricky to do. So you can see this pericellular fibrosis that we have here. And I'm sure you'll agree with me that the Sirius red demonstrates the fibrosis far better than the Masson trichrome. The Sirius red also is good from the point of view of picking up delicate fibrosis. So what I want to do now is go back to the H&E. So you've got an idea of what is happening in this liver. And then when we have a look at the H&E in closer detail, we can see that you've got this. I'll just get to the interface here. You can see that we've got hepatic parenchyma, which looks pretty busy on its own right. And then here you've got these sheets of inflammatory cell infiltration. You can see that there are proliferating bile ductules. For example, these are proliferating bile ductules here and here. So there's florid ductular proliferation accompanied by neutrophils. And whenever you get bile ducts proliferating, you tend to get neutrophils accompanying that. So it doesn't always mean that there's coexisting infection. Here you can see you've got entrapped hepatocytes amongst this inflammatory infiltrate. Again there. Then what I want to show you in closer detail are the components of this inflammation. So if we look down here just to orientate you, here you've got the hepatocytes. There's a little bit of cholestasis there. And this is a whole row of plasma cells. For example, there, this is a bile duct. There are more plasma cells up here. A couple of significant things about these plasma cells. First of all, they're closely associated with the interface inflammation. So we call this interface inflammatory activity. And you can see the spillover of this infiltrate from this broad-based inflammation here into the adjacent parenchyma. So they're participating in the interface inflammatory activity. And in some areas, you can actually see plasma cells, excuse me. So here, for example, we can see a plasma cell and another couple here that are deep within this interface region. More plasma cells here as well. So let's just have a quick drink. And then you've got the clustering of plasma cells. Now, whenever we see clustering of plasma cells, as I showed you earlier, you have to think of autoimmune hepatitis. Right. So now what I want to show you, in fact, let me just go back. In fact, no, I'll stay on this, sorry. I'm juggling things around a little bit. One of the features of autoimmune hepatitis is the presence of what we call imperipolesis. And imperipolesis means the phagocytosis of cells. And in this particular instance, it's imperipolesis of lymphocytes. So I'm losing my voice. So if we look here, that's a lymphocyte. And here we have another lymphocyte that is being phagocytosed by these hepatocytes. And I think if you look around, more lymphocytes there. There's a lymphocyte nucleus. There's a hepatocyte nucleus. And you can see this florid interface inflammatory activity. Look at all this, quite impressive. I want to go back now to the reticulum stain. So this is that same area. So we were looking at the interface between the normal hepatic parenchyma there and this area here. Now this is not a portal tract. Why is it not a portal tract? Well, you can see that these delicate strands here, this represents the collapsed reticulum framework in the pre-existing hepatic parenchyma. So what has happened is that there has been extensive hepatocyte loss. And in fact, we will call this panzonal hepatocyte loss. And because of its extent, it's extending from the portal tracts to the central veins. And you can see the reticulum fibers. Now, when you have patients who have massive necrosis of the liver, for example, secondary to, let's say, hepatitis A or hepatitis B or a toxic cause, such as mushroom poisoning, then what happens is the hepatocytes die and the reticulum collapses very much like a sponge. I always teach the registrars and the medical students that if you take a sponge and squash it with your hand, that's exactly what happens to the reticulum framework. And then if the liver regenerates, then the liver cells regenerate along this reticulum framework. And in a case of massive necrosis of the liver can return to its perfectly normal pre-necrotic state. So that shows you the extent of this reticulum collapse. And then finally, just to show, I don't remember, I can't recall what the ferritin level was in this particular patient, but there was also evidence of iron overload. And here you can see the granular iron, which we assessed to be sure stage 3. So final diagnosis then, autoimmune hepatitis with panzonal necrosis, almost amounting to submassive necrosis in some areas, although clinically I don't think he was that fulminant, but certainly panzonal necrosis, and we called this A3F2, according to the Metavert score. Thanks, Dylan.
Thanks, Martin. Just to summarize, I mean, there are morphological issues here and etiological issues. From a morphological point of view, how worried are you about this collapse as a prognostic factor? And does the fibrosis worry you? So,
Chris, yes, I think it is of concern. I think particularly because of the etiology, that he does have autoimmune markers that are positive. And unless this is arrested, he certainly could go on and progress to chronic liver disease.
And we should just summarize the hallmarks of autoimmune on this biopsy.
Right. So what we've got then in summary is a florid inflammatory cell infiltrate, which is rich in plasma cells and lymphocytes. There is clustering of plasma cells. And there is imperipolesis of lymphocytes by hepatocytes You don't always see the imperipolesis, but the literature considers that to be diagnostic.
And then finally, there is a question from Mark Sunderup on the chat. Any bile duct targeting or just duct proliferation?
So Mark, yeah, that's a good question, because there doesn't appear to be any bile duct targeting at the moment. And I think his AMA M2 sorry, his AMA M2 was borderline positive. So I think the florid nature of the infiltrate may be hiding things, but it doesn't really look as though there's any bile duct injury at the moment.
Obviously, the issue there is an overlap syndrome.
Sure, doesn't look like an overlap, not at the moment. But I think that may become apparent as the inflammation recedes.
Okay, thanks, Martin. Dean, do you want to continue?
Sure.
Unmute yourself, Dean.
Apologies for that.
There we go.
So Mr. CM was then, in summary, had an autoimmune hepatitis, possible overlap syndrome, but we had initially stopped his azathioprine, converted him to intravenous steroids. His blood cultures did reveal a Salmonella typhimurium, for which he received 14 days of sensitivity-guided antibiotics. You'll see his ALT, which started off on the previous slide above 500, had started coming all the way down. And he did have uncontrolled sugars during his time in the hospital and needed insulin for control. He was discharged with much improvement in his liver function, and we aim to start him on an immunomodulator at his 2-week follow-up with a repeat set of bloods. So he's currently just on his prednisone 60 milligrams daily and his insulin. So moving on to case.
Should we just open the forum for a few questions, maybe? Are there any questions from anyone? Unmute, and you're welcome to ask or post them on the chat line. One of the things, Dinan, is that there seem to be, go back to his blood profile if you can, there seems to be quite a cholestatic, I mean, the ALK phos seems like it's rising, or it was the gamma GT, and then dropping. That was while his transaminases are falling. I mean, he was septic at that time, was he?
Yes, he was septic in the first few days. The first sort of 3 bloods on the slide was when in the first sort of 72 hours of antibiotics. So he had antibiotics on board. He was septic at the time. And therefore we weren't too concerned initially about that slight increase, which then started decreasing again afterwards. So it could have just been sepsis related, high dose steroid related, a few other.
Okay. Any comments from anyone? No?
Chris Bilal's also got a question. I've got a comment as well, if I may, just to follow up on Professor Sunderup's question as well about the overlap syndrome. In these particular circumstances, it's very important from a pathology point of view to look at the Orsine stain, because if there is copper-associated protein, that is usually a fairly sensitive and good indicator that there could be an overlap syndrome. But certainly in patients where we see copper, it's not always absolute, but where we see copper, we always raise the possibility that there could be bile duct pathology.
Mark, why don't you unmute on video and give us your comments or questions?
Thanks, Chris. I actually just posted it in chat. It was just two questions to them. Then the one I heard him suggest that the patient was on IV steroids. I just wondered, what was the patient not able to take oral, or what was the rationale for that? And then vis-a-vis the canalicular component, which could of course also relate to the ASA sepsis, obviously, but is an MRCP being considered?
Sorry, Prof. Can you hear me?
Yeah.
So initially, yes, we had a look at his ducts, and his ducts were normal. He had, just to follow up on the overlap possibility, his IgM was normal. He did not have any copper on his biopsy. So yes, leaving it as a consideration, but he has started, we've seen him once at clinic since then, and his ALP GGT have dramatically decreased. The concern just from the salmonella side of things was that the bile could be a reservoir for the infection, and thence we put down some of that inflammation around the bile ducts to the actual infection over and above the underlying disease process.
Yeah, I think the important thing here was that he appeared to be deteriorating, but in fact the deterioration was more from a septic point of view rather than a hepatic parenchymal point of view. So that's a very important issue to always appreciate. Deteriorating liver-associated enzymes don't necessarily imply deteriorating disease. Bilal, you had a question?
Yeah, just more of a comment. Just regarding the case of differentiating then your patient with that you're newly diagnosing autoimmune hepatitis. What's an acute severe autoimmune hepatitis? So that's, you know, in the presence of jaundice, and you can have an elevated INR but no coagulopathy, and then finally a fulminant autoimmune hepatitis. I think it's important just to try and draw some distinction between them because of the role of liver transplantation in your fulminant autoimmune hepatitis, and where, you know, bashing on with steroids may actually be deleterious for their outcome, rather than getting them to a transplant center and getting them transplanted.
Yeah, about 10% I read was 10% of patients with autoimmune go on to liver transplantation. So it is a condition that we need to respect. What we're doing with time. Okay, maybe we'll go on to the second case, Dinan.
Sure. Sorry, Prof. I don't think I answered one of Prof. Sandarap's questions there. The choice of IV steroids was just for the first 48 hours. He was feeling nauseous, had a lot of diarrhea, and he was septic at that point. So when we started him initially on the broad spectrum antibiotics, we had him on Solucortef initially, but on day 3 we had dropped him to prednisone 60 milligrams daily.
Thanks, Dinan. Chris, I wonder if I can just raise a point, because perhaps it's in sort of a clinical nuance, and that is excellent case, Dinan.
Can you just speak a bit louder, Mark?
I said, is that better, Chris?
Yeah, a little bit.
I'm saying I think this case represents an aspect that has been excellently presented by Dinan, and that is the issue around the histology, perhaps just tempering your management. And when you see such a severe injury, particularly with autoimmune, and you're going to come in with steroids, I think one perhaps should exercise a little bit of caution in terms of your actual steroid dose initially, because what you do is you run that risk of tipping them over into the risk of sepsis. And it's finding that sort of sweet spot between immune suppressing them and trying to stave off significant sepsis that is always the real clinical challenge. So thank you for an excellent case.
Thanks very much, Mark. Okay, Dinan.
So for case 2, we have Miss MV, who's a 60-year-old female. She received a liver transplant in 2015 for NASH cirrhosis, and this was ascribed to a previous jejunal ileal bypass surgery. Post-transplantation, she developed pulmonary thromboembolic disease. After a few months of warfarin therapy, represented with an intracerebral bleed, after which the warfarin was stopped. In 2018, had an episode of acute T-cell mediated rejection with a Banff score of 8 out of 9. This responded well to solumedrol pulse for 3 days, and her liver function improved. She had renal dysfunction, which was intricately related to her tacrolimus dosage, and had previously been intolerant to azathioprine and everolimus, and being 5 years post-transplantation, her maintenance immunosuppression was just tacrolimus. Her LFT at her last follow-up in December, which we'll see now, was absolutely normal, and now in April presented with clinical symptoms of a UTI with a deranged liver function test. So looking at the bloods, you see her December bloods on the left-hand side with a normal ALT, AST, essentially completely normal liver function, a globulin gap normal, just to note, and a tacrol level slightly higher than we'd like it to be with renal dysfunction. So at her December follow-up, her tacrolimus dosage was adjusted, aiming for lower levels between 3 to 4, being 5 years out and having an underlying diagnosis of NASH. And she now presents with a ALT more than 10 times the upper limit of normal, elevated ductal enzymes, elevated bilirubins, but interestingly, she had this widened globulin gap, and she still had a bit of renal dysfunction, but this was thought to be UTI related. So in terms of a workup, as I shown earlier, her imaging studies were normal. The portal vein was patent, hepatic artery was patent. Her viral studies were negative. In terms of an autoimmune workup, she had a smooth muscle antibody, which was now positive, which was previously negative, sitting at 1 in 160, an immunoglobulin G of 33.3 with an enlarged globulin gap. However, the rest of her autoimmune markers were negative. The urine grew an E. coli, which was pan-sensitive. She received intravenous rocephin for it. And her septic markers improved over the first 48 hours with no improvement in her LFT. So considerations at this point was an episode of acute rejection, sepsis-related deranged liver function, but it had not improved with the treatment of the sepsis, or the entity of de novo autoimmune hepatitis, at which point we biopsied her and asked Prof. Hale to review. Prof. Hale?
Right. Thanks, Dylan. Oops, we seem to have a problem. Here we are. Everybody's
It's coming up.
Great. Okay, so this is another very, very interesting case. And it's a good quality biopsy. And certainly we must here pay our ever indebtedness to the radiology people at Donald Gordon. They really do excellent biopsies, and it makes interpretation of these so much easier. So what we've got is a biopsy, once again, that you can see is quite busy in some areas. This is a portal tract here. And one can see that in some areas, there's quite considerable expansion of the portal tracts. There's a suggestion of bridging, which you can see, for example, oops, sorry.
Marked.
On the H&E. You can see how busy this biopsy is. And broad areas of fibrosis as well, with this blue inflammatory infiltrate, and then interspersed occasional foci of large droplet steatosis. You'll recall that she had her transplant was because of end-stage liver disease secondary to NASH. But there's insufficient steatosis in this biopsy really to be causing a significant liver injury like this. So what I want to do now is show you the reticulin stain. And this is the retic, low power, and you can see both cores, and you can see that they're really extensive architectural distortion. And this certainly is concerning when you consider that the patient's history, in fact, has been relatively innocuous, for want of a better word. She's had a single episode of years ago, but we really have this extensive liver injury which has taken place. And certainly one gets the impression that this has probably progressed to cirrhosis, progressing to cirrhosis if it hasn't already. We're going to turn to the mass unfolding. Unfortunately, I haven't got a serious rare on this because this biopsy came in at the time of the Great Johannesburg Hospital fire, which we are still trying to sort of recover from. Our histopath has taken a little bit of a dive subsequent to that because we can't access our lab yet. So here we've got fibrosis. You can see this extensive fibrosis. You can see that there's bridging, which is taking place. For example, there you can see typical bridging between central regions here and portal tracts here. And then if we come down here, you can see, for example, that we've got a portal tract to central vein and another portal tract there. So we've got portal central and almost portal linking in some areas. So we have at least architectural distortion in this biopsy. So this would be an F3 fibrosis at least. I want to now look at the H&E, go back to the H&E. And the H&E is really quite florid. So we have this infiltrate going straight down onto these expanded portal areas. Here you can see the hepatic arteriole, bile ducts, there's a little bit of bile ductular proliferation. I think that's probably another hepatic arteriole there. And then I want to show you this here, because we have this lymphocytic inflammatory infiltrate, which is dense. It's showing evidence of aggregation. And in this area here, you've got centroblasts that are present. So these are larger lymphocytes, and this is the beginnings of a germinal center. So when you see this, by definition, this is an autoimmune hepatitis. Often in the cases of autoimmune hepatitis, as we saw in the previous one, you just get aggregation. And whenever we see aggregation like this and some sort of degree of consolidation of the lymphocytic infiltrate, certainly what that raises the suspicion of autoimmune hepatitis. And then when we look closer at these cells, we can see that there are hundreds, literally, of plasma cells. These are all plasma cells. We actually have sheets of plasma cells. I mean, this has progressed beyond clustering. These are now sheets of plasma cells. We've got continuing interface activity. For example, there you can see plasma cells infiltrating into the adjacent hepatic parenchyma. And similarly here, you can see this infiltration and this interface inflammatory activity. And you can see numerous plasma cells participating in this inflammatory activity. You can see necrotic hepatocytes. So these are almost like Councilman type bodies. Necrotic hepatocytes sitting in the sinusoids. They're certainly readily identifiable. And then if we go to this area here, I want to show you this. There's a hepatocyte, and there is a lymphocyte sitting right next to the hepatocyte nucleus. So this is another example then of emperipoiesis of of lymphocytes by hepatocytes. But it became quite difficult to see. And the problem is that often lymphocytes are present in the sinusoids, and it can be quite difficult to be absolutely sure that they're sitting in the cytoplasm and not the sinusoids. And there is another focus. And I don't think I've ever seen as many lymphocytes such as this here, where you can see we've got 4 or 5 lymphocytes surrounding, almost resetting around that hepatocyte nucleus. And often, you know, one struggles to find one, but here we've got half a dozen of them in a single hepatocyte. So given that the patient has a pre-existing diagnosis of NASH, this would then be regarded as de novo autoimmune hepatitis, and using the metaphor score gave us a score of A3, F3 with progression towards F4. Thanks, Dylan.
So Martin, are there any differences histopathologically between a de novo autoimmune hepatitis and that develops in the transplanted liver?
So, Chris, the answer to that is no, they're not. There are no differences. They look very similar. And in fact, the BAMF classification requires that you have to know what the pre-existing disease was prior to transplantation. So if this patient, for example, had autoimmune hepatitis as a cause of the end-stage liver disease, then we would call this recurrent autoimmune hepatitis. But as this patient has NASH as a pre-existing disease, then we will call it de novo autoimmune hepatitis. But it is
and there's a question from Mark, were there any specific zone 3 changes?
Mark, yes, there was, or there are. Thanks for that. So, for example, in some areas, such as this here, I glossed over that, sorry, but this is a central vein. And here you can see changes of endothelial disruption. You can see the plasma cells, once again, participating in this. And you can see this red cell extravasation. So these changes are equivalent to basically endothelialitis. And it requires identification of that. We also need to recognize that endothelialitis is also a feature of autoimmune hepatitis and can occur in that entity. So here, for example, in the portal tract, you can see that there is subendothelial aggregation of inflammatory cells. You can see focal lifting of the endothelial cells. And so we have endothelialitis then involving both portal veins and central veins. And I think it's quite a difficult area to really understand, because I'm not sure that I fully understand yet the difference between recurrent autoimmune hepatitis. So if a patient has a pre-existing disease of autoimmune hepatitis, we would still give it a BAMF score. Whereas in this particular instance, it seems that you don't give it a BAMF score, you just call it de novo autoimmune hepatitis. And I think this is something that has not really been fully sorted out in the literature. Does that answer your question, Mark?
Thanks very much. Dylan, would you like to continue and maybe wrap up?
Sorry. So Ms. Van Zyl received a 3-day pulse of IV Solumedrol, after which her liver function improved. However, there was a suggestion on the biopsy profile about the large duct pathology that she might have. We proceeded to do her MRCP on her, and there was a suggestion of an anastomotic stricture at the surgical site. And she then subsequently had a PTC. Unfortunately, that was complicated by an episode of acute pancreatitis. So she's currently still admitted with a resolving acute pancreatitis.
Yes, thanks, Dana. Sorry, I forgot to show you that. Let me just do that if I can just take the screen back again. So,
while I have you on, if you could just tell us about the difference between that, what she has, and a plasma cell rich rejection, how it would look on the biopsy.
Yes, so thanks, Dan. That's also an important point. So let's first of all look at the ducts. So there's the ductular changes, which I sort of glossed over. Sorry about that. But here you can see we've got these proliferating bile ductules. And one can see that there are neutrophils that are closely associated with these bile ducts. And in fact, they're actually infiltrating into the lumen of the bile duct. Now, also the other thing that this particular patient had was a urinary tract infection. I think the patient had an E. coli, if I remember correctly, but there was no septicemia. And that's also an important point, because septicemia can also cause these biliary changes in pathology. So from a pathological point of view, so it's an important thing for the pathologist to ascertain if there's background septicemia, and that you don't overcall, in fact, that this is duct pathology. But there was no evidence of septicemia. And you can see these neutrophils here. They're closely affiliated to this ductular epithelium. You can see the ductular epithelium is appearing a bit disruptive. You've got these intraluminal neutrophils as well. And here as well. So that would be, that's indicative of potential bile duct pathology, and typically the sort of thing that you get with underlying cholangiopathic pathology, which can be variable. In this particular instance, in view of the patient's history, anastomotic strictures come to mind, depending on the anastomosis, whether there's a roux loop or not. One should also think of ascending cholangitis as well. But as Dylan said, that all was all clear. So at the moment, we don't really have a specific cause for this this neutrophil-associated ductular pathology. Just turning to your question about plasma cell-rich rejection. So you're right. So plasma cell-rich rejection occurs in patients who, in whom the pre-existing diagnosis is not autoimmune hepatitis. So if a patient, for example, if this was a patient who might be, when she was a NASH, so if this was less in terms of the numbers of plasma cells, then I would probably call it a plasma cell-rich rejection. But I think in view of the enormity of this inflammatory cell infiltrate and also the immune markers, we would upgrade it to the autoimmune markers, that is, because she is positive, we would upgrade it to de novo autoimmune hepatitis.
Inan, aren't you alarmed at the rapidity of this presentation? I mean, in December of the previous year, liver-associated enzymes were pretty normal.
Yes, Prof. That's a huge concern. She's had normal LFTs since her rejection episode in 2018. And to say that this biopsy has F3 fibrosis in the background, I guess it would be typical of an autoimmune type picture with slow damage progressing in the background without us noticing it, but it is a big concern. So once we've got her settled from the pancreatitis point of view, our plan is to give her rituximab and use that to maintain both immunosuppression with a bit of tacrolimus and steroid in the background. But yes, it is a huge concern at the moment.
And Bill Bobot, do you think that her immune suppressive therapy post-transplant might have had a role to play in this rapidity, in this presentation?
I think the tapering certainly had an effect. Tacrolimus is, a third-line agent in order to treat treat autoimmune hepatitis, and has been used successfully for that purpose. I think with us cutting back from December, it is possible that she developed this fibrosis in those 4 months. So certainly.
But presumably she's had this condition for much longer, and it raises the concern that your liver-associated enzymes sometimes are not a true reflection of what is happening in the liver with this condition. And it's an important point when you actually maintain these patients. How far do you drive your immune suppressive therapy, and are you aiming to absolutely normalize your transaminases to absolute normality, or will you accept some kind of minor abnormality? I've seen patients who smolder with very little in their liver-associated enzyme abnormalities in the maintenance phase on immune suppressive therapy, and actually develop fibrosis and cirrhosis over long periods of time. So is it important to absolutely normalize your enzymes?
I think that is important, along with normalizing your IgG fraction. And what's furthermore important to recognize is that your laboratory reported value is not necessarily where you should be looking at. For a young female, for instance, your ALT should be sitting approximately 19. So if you're accepting a transaminase of 40, which the lab may report as being, essentially normal, it's actually still twice upper limit of where your target should be.
And also, we don't know what the normality or variants are in sub-Saharan Africa. They might be quite different. Mark Sonderup, any comments from you?
Chris, no, not at this stage. Thank you very much.
And then some comments maybe from our sub-Saharan colleagues. I mean, how are you seeing this condition? Professor Christian Tsuton is on from the Cameroon. Hello, Christian. Perhaps you could comment, maybe unmute and say hello. It's very nice to see you every week. Anyone else want to comment on whether they're seeing this condition in sub-Saharan Africa? No. Any comments from anyone else? We have a few minutes left. Martin, final comments?
So thanks, Chris. Yes, I think I would just like to, underline your comments about, and also Bilal's comments on the progression that autoimmune hepatitis can do, literally under our noses. And we've seen several of these patients that not so long periods either. I mean, I think you had a patient last year who literally progressed from no cirrhosis to cirrhosis within 2 years. And it's frightening, in fact, how this can progress. And I think my impression is that it's almost an underdiagnosed entity sometimes. I think we don't look hard enough for it.
Sure, I think that's going to be the issue in sub-Saharan Africa. Well, thank you very much. It remains for me to thank you, Martin, very much for your brilliance and your teaching skills, and makes these sessions so interesting. And thanks, Dinan, for excellent case presentations. Thank you also to ECHO New Mexico and ECHO India for their support. Feedback forms, as usual, are available, please, for your feedback. These sessions are recorded and will be available on the foundation website. And thank you very much, Cheryl, for keeping us in tow, and Karen for all your backup and support. And then finally, next week, our session is devoted to patient blood management. So we look forward to seeing you next week. Thank you, everyone, and good night.
Thanks.